Hello and welcome to this edition of Pathcast, the channel that has been broadcasting and archiving the pathology knowledge base since 2016. My name is Emilio Madrigal, transmitting live from Atlanta, Georgia. Today we welcome Dr. Nicole Panarelli, who is an associate professor of pathology at Albert Einstein College of Medicine, Montefiore Medical Center in the Bronx borough of New York City, and she is joined by my colleague Wei Zhang. Dr. Panarelli will be presenting a gastrointestinal pathology talk titled Bugs, Sprue, Drugs, and More: Adventures in the Small Intestine. As always, please remember that you can ask questions during the session by simply typing them as comments in the Facebook comment section of this live video, and we will pass them along at the end of the broadcast. So with that, I will turn the microphone over to Dr. Panarelli.
Good afternoon. Thank you, everyone, for joining us here at Monty and out there on PathCast. Today, we're going to be going over some interesting small intestinal cases. I'm sure that everyone remembers in medical school when they heard the conventional wisdom of flat and blue equals sprue. And then you might remember when you came to pathology and you discovered that the flat blue small intestinal biopsy actually evokes a pretty broad differential diagnosis. So the goal of this session is to look at some of those entities and talk about their important features and think about the ways that we can distinguish them in the instances when we can do that. So let's get it started with our first case, which is a classic and is going to set us up for the remainder of the session. So this is a typical presentation of a 30-year-old woman who finally came to her doctor because she's had these months of diarrhea and abdominal cramps. She's got a iron deficiency anemia on her routine labs, and so her internal medicine doc ordered serologies and sent her to the gastroenterologist for an EGD. Okay, so hopefully you can see. Okay, cruising around her biopsy at low power. This is from the duodenum, but from the low power, we certainly get the impression that the villus architecture is extensively effaced, and you get that gut feeling like this is just a little bit too blue. So we go to higher power. We see that the surface epithelium is really teeming with lymphocytes here. Oh, I can point with this, sorry. Is really teeming with extra lymphocytes. And then cruising around the lamina propria, we see that it is really expanded by a lymphocyte and plasma cell-rich infiltrate. In some other areas, you can appreciate elongation of the crypt or crypt hyperplasia. And taking all these features together in a patient with a typical presentation and confirmatory serologies, this is really a slam dunk for the diagnosis of celiac disease. So the classic features I've just listed here for your reference are those that we saw in this case. We have marked villus blunting, hyperplastic crypt, lamina propria expansion, and an increase in intraepithelial lymphocytes. As you all know, celiac disease is a reaction to dietary gluten in genetically susceptible individuals, in particular those who bear the HLA-DQ2 and DQ8 haplotypes are at higher risk for development of celiac disease. Although no one test is perfect, the serologies that test for tissue transglutaminase and endomysial antibodies, and those are IgA antibodies, which becomes a very important piece of information, are highly sensitive and specific. On the other hand, the endoscopic findings are not reliable and very variable, and so that's why biopsy really remains the gold standard. And the diagnosis of celiac disease is very straightforward, usually, when all the histologic, serologic, and clinical features fit together. But as you also no doubt know, patients are much more savvy these days, and they tend to present earlier with whatever disease they might have. And so when we see a biopsy from a patient with celiac disease, it's more common these days for it to look like this. Not quite so flat, not quite so blue. So in this duodenal biopsy, we really have pretty good preservation, or partial at least preservation, of the villus architecture. But then when we go down on higher power, we see that in these villi, we don't have the normal decrescendo, that is a decrease in the lymphocytes. Sorry, it's just letting me focus. as we go from the crypts up to the tips of the villi. So we have increased intraepithelial lymphocytes with partially preserved villus architecture and a little bit but less expansion of the lamina propria. But in the appropriate clinical setting, this too, of course, is compatible with the diagnosis of celiac disease. In most patients who are diagnosed with celiac disease, the histologic abnormalities and the clinical features will remit pretty rapidly upon withdrawal of dietary gluten. But in a small subset, the symptoms will either persist or recur despite adherence to a gluten-free diet. And so if that happens and goes on for a year, those patients will fall into the category of refractory celiac disease. And refractory celiac disease is further subclassified based on the predominant phenotype of the intraepithelial T cells. Type 1 refractory celiac disease, the T cells co-express CD3 and CD8, which is of course normal, but in type 2, they lose CD8 expression. And this is the type that is at risk for progression to enteropathy-associated T-cell lymphoma, which, as you know, is quite aggressive lymphoma with high mortality. So that's something to be looking out for. Now, collagenous sprue is a slightly different animal. There are some well-documented cases in which collagenous sprue represents a progression of celiac disease in patients who initially responded to a gluten-free diet. But in others, there's never a response to gluten-free diet, and so it's probably not actually the correct stimulus. Some investigators think that it might be a response to other dietary proteins, and proposed proteins include some animal proteins, poultry, fish, even soy, but it's probably different and varies from patient to patient. In others, collagenous sprue associated with collagenous colitis or gastritis and may respond to steroid therapy. Now, to make matters slightly more complicated, about 10 or so years ago, a histologic pattern that's completely indistinguishable from collagenous sprue was noted in a small group of patients, all of whom were taking the angiotensin II receptor antagonist, olmesartan, for management of their hypertension. Now, as I said, these patients had a histologic picture and a clinical picture. It was completely indistinguishable from collagenous sprue. Many had severe diarrhea, some even requiring hospitalization and TPN, but they had no response to gluten-free diet and no serologies that would indicate celiac disease. And so really what that was a reaction to their angiotensin II receptor antagonist, and that's an important possibility to keep in mind when you see that pattern of injury, because these patients won't respond to anything except for a change in their medication. So with that, I think we're ready to move on from case one into our next entity. So this is a case of a 35-year-old man who presented to our hospital complaining of 10 days of nausea, vomiting, diarrhea, and weight loss. And so severe were his symptoms that when he came in, he was actually in acute renal failure. Of note, his cryptosporidium antigen was positive, and his imaging showed thickening in the small intestine and mesenteric lymphadenopathy. I didn't include a lot of endoscopic images because, for the sake of time, but I had to show you this one because it's so striking. His duodenum was just completely carpeted in these lumps and bumps that even raised the clinical suspicion for an occult polyposis syndrome. But that's not what we had. Here's what we saw. Okay, so again, we have many samples of duodenal biopsy, and many of them show a complete loss of the villus architecture. We can focus a little bit better here. In some areas, there are a few villi that are still hanging around, but for the most part, it's really quite flat. Let's take a look at higher magnification. Okay, so again, like the previous cases, there is an increase in intraepithelial lymphocytes at the surface of the mucosa, but the more striking thing in this case, which you've probably noticed, is these really enormous and sort of dramatic lymphoid follicles. And we did do our diligence in this case and have our heme path folks confirm that these were in fact reactive lymphoid follicles. And so with that reassurance, this degree of reactive lymphoid hyperplasia in the small intestine should raise the possibility of a primary immunodeficiency. And so we consulted with our clinical colleagues, and this patient did turn out to have selective IgA deficiency, which is the most common among this group of disorders, primary immunodeficiencies, that is. And it results from a defect in the maturation of IgA secreting plasma cells. Now, IgA, as you probably know, is the main mucosal immunoglobulin. And so patients who are symptomatic from this disorder experience frequent respiratory and gastrointestinal infections. In the GI tract, they tend to have repetitive problems with giardiasis and strongyloidiasis. But many patients with this disease are asymptomatic, and so its actual prevalence is probably underestimated. Interestingly, 2 to 3% of patients with celiac disease have a selective IgA deficiency, which is a much more higher prevalence than that seen in the general population. And unfortunately, because, as I mentioned earlier, those screening serologies for celiac disease rely on detection of IgA, they're not reliable in this patient population. There are some newer tests for IgG antibodies to gliadin peptides that can be helpful in this population. But the duodenal biopsy samples in folks with IgA deficiency and celiac disease, or patients with IgA deficiency and without celiac disease, can be completely indistinguishable from a immunocompetent patient who has celiac. So the only reliable distinguishing feature is response to a gluten-free diet. So sometimes it's just a question of trial and error about whether these patients are experiencing diarrhea from other complications of their IgA deficiency, or if it's celiac disease that's the culprit. Okay, we're ready to move on to the next one. This is a case of a 65-year-old woman, and I will make note of her age a little bit later because it's important, who was referred for management of suspected inflammatory bowel disease. Okay, so I'm taking us a little bit further south in this case, and so these biopsies come from her terminal ileum. And unlike the previous one, you can see that the villi are actually very nicely preserved in this terminal ileum biopsy. But you might think, well, you might think this is normal and just move on, or you might stop and think, wow, this really looks a little bit empty in a strange way. And if you take a higher look at the lamina propria, you'll actually note that there's a complete absence of plasma cells. Wait for it to focus. The plasma cells are completely absent in the lamina propria of this patient's terminal ileum. So that's an unusual finding. And we also got some biopsies from her colon that had unusual findings as well. And I'll show you what we saw there. Here's her colon biopsy, one of her colon biopsies. Again, has that sort of cleared out a little bit too pink look as opposed to the little bit too blue that we were looking at before. And if we look at higher magnification, we will see some poorly formed granulomas, some associated with crypt rupture, some not associated with crypt rupture. And in some of the crypts, there's quite a bit of confluent and single cell apoptosis. So we have an absence of plasma cells, some granulomas that produce overlap with IBD, and apoptosis. And the diagnosis for this patient, if you haven't already guessed it, is common variable immunodeficiency. Common variable immunodeficiency is not really a single disease, but it results from one of several mutations that cause immunodysregulation either in the T cell differentiation, T cell response, or immune tolerance to antigens. Most cases are sporadic, but autosomal dominant and autosomal recessive patterns are described. And I've listed the diagnostic criteria for your reference, but I want to point out that this diagnosis cannot be made before the age of 2 when people sort of immunologically catch up. But it's not uncommon to see, as we did in this case, patients go through their lives and get to middle age being treated for whatever complications they get without ever having the correct diagnosis made. So that's something to be aware of with common variable immunodeficiency. It's also characterized by recurrent respiratory and gastrointestinal infections, but patients, because of defects in immune tolerance, are at risk for development of a host of other autoimmune diseases as well. And unfortunately, again, due to decreased mucosal immunity, they're at risk for development of gastrointestinal B-cell lymphomas and adenocarcinomas. Now, common variable immunodeficiency, of course, affects all segments of the gastrointestinal tract, and it can have many, many different histologic profiles. So in the stomach, you can see patterns that look like autoimmune gastritis or autoimmune pangastritis or lymphocytic gastritis. In the colon, as we saw, it simulates inflammatory bowel disease many times, including granulomas, but can also look like microscopic colitis. And in the small intestine, it can simulate our old friend celiac disease with increased intraepithelial lymphocytes. And interestingly enough, the patients can have spuriously elevated anti-TTG and anti-endomysial and anti-gliadin antibody titers. They can also have spuriously elevated other autoantibodies as well. But the thing that helps us tell common variable immunodeficiency from celiac disease really is that decrease or lack of plasma cells, because we don't expect that from celiac. We expect to see an expansion of the mucosal plasma cells. And those frequent apoptotic bodies, also not a feature of celiac disease, but very common in common variable immunodeficiency. Okay, I just want to say a word about the plasma cells in these cases before we move on to case 4, because I've been talking about a lack of plasma cells, but actually up to a third of biopsy samples from these patients can contain plasma cells. So unfortunately, if you see them, it doesn't necessarily exclude this diagnosis. So that's just a caveat that I wanted to make you aware of. Okay, let's see what's in case 4. Case 4, we're talking about our younger patients. This is a 10-month-old boy who presented with failure to thrive, and that had been going on for some time, but he acutely got worse until his parents brought him in, and at that time they shared that they had had 3 older boys in another country who passed away shortly after birth. And so this patient, shortly after he presented, underwent endoscopy to evaluate what might be going on. Okay, so here's a small intestinal biopsy from this patient. Let's look at it. Here we go. And again, we have a partial preservation of the villus architecture. From low power, it doesn't appear to be all that increased as far as inflammation. But at higher magnification, we probably see some extra inflammatory cells up here at the surface. Apologies for some. That's really, sort of appeared non-specific in this particular biopsy. Some blunting of the villi, a little bit of increased inflammatory cells. Take a look at another. We had several biopsies from the patient. Here in the jejunum, we saw actually pretty nicely preserved villus architecture. We got this sample from the submucosal tissue that contains just a single discrete granuloma. I thought that was odd in somebody who was this young. We also got some colon biopsies from this patient, and they also appeared to be just about normal, but the way the true story goes is that an astute trainee in our institution was looking at these very closely one night and noticed that it's going to be hard to project, unfortunately, but the lamina propria of this patient's colon, I'll wait to focus. You can increase the light. Very faint, but it contains some macrophages with pale brownish gold pigment that, unfortunately, here you can see them right here. It's not projecting all that well. And so that trainee did some searching around, and he actually came up with the cause of this child's GI distress, which is chronic granulomatous disease. In chronic granulomatous disease, the patients inherit X-linked defects in the NAPDH oxidase complex, and that's the complex of neutrophils that normally kills ingested microorganisms. Now, they have chronic granulomatous inflammation because that impaired oxidative burst also fails to digest other ingested materials. So even in the absence of infection, these patients can have granulomas in their biopsies. This is a diagnosis that can be confirmed by testing the neutrophil function or the oxidative burst function of neutrophils. And in this case, that test was performed and confirmed the diagnosis. The main differential in most patients is Crohn's disease owing to the presence of granulomas and in some cases chronic colitis and mucosal remodeling like we saw here with villus blunting and intraepithelial inflammation. The pigmented lamina macropropria macrophages are an important diagnostic clue. They are usually present in these cases, and in some studies, increased mucosal eosinophilia has also been found to be a feature of chronic granulomatous disease. So the lamina propria macrophages are the really important thing to clue you in here in these uncommon cases. I've included this slide just for your reference. It summarizes the 3 most common immunodeficiencies, primary immunodeficiencies that affect the GI tract, and you can sort of look at this one at your leisure and for your reference. Okay, so let's keep moving along. This is a case of a 4-year-old boy, still with kids here, who presents with chronic diarrhea and failure to thrive. He did have IUGR gestationally and early poor weight gain. He's been having diarrhea since he was 9 months old. Okay. So we're back to flat and blue. In this case, we really see a marked expansion of the inflammation in the lamina propria. This again comes from the duodenal biopsy specimen. And at higher magnification, again, we have our increased intraepithelial lymphocytes in the surface and in the crypt. But very importantly, in this case, if we go around this biopsy, it's really difficult to find Paneth cells. Plasma cells are present, goblet cells are present, endocrine cells are present, but this is an example of this entity that shows an absence of Paneth cells, which is the key finding in this case. So let's talk about autoimmune enteropathy. I've listed the main histologic features for you. I do want to point out that these often show a graft versus host disease-like pattern with lots of single cell and confluent apoptosis. Not a prominent feature in this case, so I did just want to make a note of it. And in the colon of these patients, you can see IBD-like features. Now, autoimmune enteropathy is not a single entity. It is manifestation of a group of gene defects that cause abnormal immune recognition and regulation. The autoantibodies that can be found circulating and confirm the diagnosis include anti-enterocyte and anti-goblet cell antibodies, but they're not pathogenic. They're just markers of the disease. And these patients also can have other autoantibodies circulating, including the ones I've listed and some others. So the best described and the best known association with autoimmune enteropathy is the IPEX syndrome. I've spelled out the whole name for you here. You can memorize it if you wish, which results from mutations in FOXP3 causing defects in regulatory T cells. Patients with the IPEX syndrome have not only autoimmune enteropathy, but skin disease and type 1 diabetes and autoimmune thyroid diseases. In recent years, some other gene mutations that cause an IPEX-like phenotype have been detected, and I've also put those there for your reference. Now, IPEX is another syndrome that's described in association with autoimmune enteropathy. This is one that not only causes small intestinal disease, but disorders in endocrine organs, including the adrenal gland and parathyroid glands. Another hallmark of EPICED is chronic mucocutaneous candidiasis, and as the name implies, disorders of the ectoderm, including nails, skin, and teeth. And just in the past, I think less than 5 years, LRBA deficiency was described. And that's a defect, again, in another gene that encodes a protein with a very long name. But these patients have, besides enteropathies, profound immune-mediated cytopenias, so they really are quite sick, and it can be inherited in an autosomal dominant or autosomal recessive pattern. There's no good therapy for LRBA deficiency. The patients require stem cell transplants, and this little boy proved to have LRBA deficiency, and that is how he was treated. So there's an increasing spectrum of gene defects that cause autoimmune enteropathy, and used to be kind of thought of as a disease of young boys or boys, but adults and girls can get it, and probably due to some of these mutations that are not as well described. Okay, so with case 6, we're going back to our sort of everyday sign out, which can also be challenging. This was a duodenal biopsy from a 65-year-old man. He has some abdominal pain and bloating, but he's a vigorous guy who reports being perfectly healthy, except that he has little arthritis in his knees. Okay, so we're having a look again at quite a flat duodenal biopsy. Wait for it to come into focus. So looking at this sample, we really don't see a very good villus architecture. We probably also noticed that the surface epithelium looks a little bit attenuated or injured. And when we take a look at higher magnification, there's a sprinkling of inflammatory cells within the epithelium, although not as striking as what we've been looking at in other disorders. Here, I've just dotted an area with foveolar metaplasia or peptic injury. You may have already noticed the presence of Brenner's glands climbing up there into the lamina propria. And so the point of this case is to illustrate that peptic duodenitis can very closely stimulate celiac disease and other chronic enteropathies, as it did in this example. Certainly that suspicion was raised when the biopsy was initially reviewed. Okay, so a few words about peptic duodenitis. Of course, results from exposure to acid in the duodenum, and mild cases are marked by inflammation and this changes that we saw in this case, but certainly can have frank ulcers. In the age of H. pylori eradication, many more cases are now accounted for by NSAID use, and that was sort of set up in this case, a patient taking NSAIDs for arthritis and having resultant peptic duodenitis. And rare cases can result from gastro-producing tumors, such as one might see in the Zollinger-Ellison syndrome. Now, peptic duodenitis, how to distinguish from celiac disease? There really is quite extensive overlap, including architectural changes and intraepithelial lymphocytosis. And in patients with celiac disease, biopsies taken from their duodenal bulb may show Brenner's gland hyperplasia and foveolar metaplasia. So you really can have quite a overlap. I think the things that are most helpful to me are erosions and ulcers when present. That's really not a feature of celiac disease. And the lamina propria inflammation in the peptic picture is, and in the intraepithelial inflammation is really more mixed than exclusively lymphocytosis. So those are the features that I think are most helpful in this case. Okay. All right, we are in the home stretch. Case 7 is of a 25-year-old camping enthusiast who started having diarrhea after one of his camping trips, and he attributed it to food poisoning or poorly cooking his food with his buddies, but it didn't go away. And so he came to see a gastroenterologist about it. And here's this fellow's duodenal biopsy. Right off the bat, you can see that he has nicely preserved villi. Sorry, a low power image. Okay. Go a lot higher so we don't get so much down. So we can see nicely preserved villi, and he has every type of epithelial cell that you want to see. Pannid cells, goblet cells, endocrine cells, plasma cells are present. I think there's one little lymphoid aggregate hiding somewhere. Yes, right there. But besides not hurting anyone, besides that, everything looks normal, except if you look in the intravillous space, which I always tell our residents, it's not space, it's still lumen. You see all these little flecks. You guys see the flecks? Flecks of pink that you can easily dismiss as being either soft epithelial cells or some extruded mucin that happened during biopsy processing. But don't dismiss them so quickly. Have a peek at higher magnification. Just wait for it to come into focus. Because if you look at them, you'll see that many have the classic pear-shaped, if you cut them on FOSS, a pear-shaped contour, or sort of a crescent-shaped contour if you cut them sagittally. These, of course, are Giardia lambia, which is the most common parasitic infection, and certainly classically seen among people who camp and drink water sources, natural water sources. Also, outbreaks in daycares and those kinds of settings are very common. Now, the thing about Giardia is we all know what it is, but we often miss it because Giardia elicits no or minimal inflammatory changes in small intestinal biopsy sampling, and when the changes are present, they can include mild villus blunting or increased lymphocytes or the occasional lymphoid aggregates like we saw. But the literature shows that up to 1/3 of cases of Giardia that is present in biopsy specimens is not detected prospectively. So I'm reminding you about Giardia because if you're not looking for it, you're not going to find it. So always check the intravillous space, which you guys are, at least here at Monty, you're probably sick of hearing from me. Okay, almost done. Case 8 is of, hold on, a 31-year-old with AIDS and severe malnutrition. He presented to our ED for evaluation of intractable abdominal pain, nausea, and vomiting. Okay. All right, so here's a duodenal biopsy. Hold on, waiting for it to come in. Okay. Yeah, almost finished. There we go. So another example of duodenal biopsies that from low magnification is looking pretty flat. For this one, from low power, the thing that stands out to me is that the villi are not only flat, but the ones that are surviving are really expanded and almost sort of like club-like. You're also probably thinking that in contrast to the other cases, this one appears to be quite pink. So let's take a look at what's responsible for that. Okay, so we see, you may not be surprised, a lamina propria that's absolutely packed with histiocytes. And when we take a high power look, sorry, just bear with us while we focus. Okay. Don't know if those watching can really appreciate it, unfortunately, but these histiocytes have a particular look to their cytoplasm, which is to say that they are sort of striated. And that's characteristic of this entity, not just any foamy histiocytes, but histiocytes with like a sort of a streaky look to their cytoplasm. Let's see if I can find a little bit of a better area. Maybe in here you can see how they're sort of streaky, not just a cutting artifact, but the real thing. And so that look to the histiocytes is characteristic of Mycobacterium avium intracellulare complex, or MAC. The duodenum, as you know, is the most common site, followed by the rectum for MAC infection in the gastrointestinal tract. That histiocyte expansion is reflected in the endoscopic findings. People describe seeing raised whitish yellow nodules endoscopically in this patient. We know the classic appearance of this disease in the immunocompromised host, which is exactly what we saw here, expanded lamina propria with histiocytes containing the organisms. But MAC does occur in the immunocompetent population as well. And in those patients, there will be a sort of more typical granulomatous response. And so just to prove to you, I did bring along our AFB stain. You can see the innumerable acid-fast bacilli in here. Hopefully, if we adjust it a little bit. And as you probably have heard before, these organisms are also positive on CASD. So here you go, 2 good histochemical stains to confirm your suspicion of MAC. Okay. Okay. Case 9 is a patient who is on chemotherapy with neutropenia and is evaluated for chronic diarrhea. This is a little bit of an older case, but it's a good one. A very similar appearance to the last one, a flat mucosa characterized by just massive expansion of the lamina propria by foamy, or not necessarily foamy, but by histiocytes. And let's find a good area to focus on, because these have a different high power appearance from the ones that we saw in the last case. So let's see. Not quite. So these histiocytes contain little punched out round inclusions with a peripheral halo. Unfortunately, it's not projecting that well, but I will show them to you on histochemical stain. And that sort of, you can see them on H&E, and those little round, sort of grayish organisms with the peripheral halo are characteristic of histoplasmosis. I'll show you the histochemical stain where you can see them much better. PSD, can I also use GMS if you prefer. Here's a decent area where you can pick out multiple, unfortunately, again, not projecting so well in this case, but multiple small little CASD positive yeast, intracellular yeast, characteristic of histoplasmosis. So histoplasmosis, as you know, is endemic to parts of the United States and South and Central America, and it starts out as a pulmonary infection that can persist in the immunocompetent individual for life and be completely asymptomatic. But in immunocompetent patients, it disseminates hematogenously to the GI tract, as well as the bone marrow, liver, and spleen. And the diagnostic organisms are these small ovoid yeasts that, if you can catch budding, they show narrow-based budding, and on H&E have this peripheral halo that's very characteristic. The immunocompromised hosts don't mount a granulomatous response, unlike the immunocompetent ones. So again, we see these large macrophage infiltrates with histiocytes that are just stuffed with the organisms. Okay, The last case I've called a bonus case because I'm cheating a little bit. This is a gastric biopsy, but it's a rare bird, and so I thought I would just show it to everyone for sort of enjoyment. This is a 40-year-old carpenter. It's the classic presentation who presents with weight loss, diarrhea, and arthralgias. And so he had some GI biopsies. His eye's a little bit faded, but it's another case with these expansile macrophage infiltrates, but again, happens to be in the stomach. It's macrophage infiltration that raises suspicion for an infectious etiology. And this was a patient who proved to have Whipple disease. The villi sort of best highlighted here on this TASC stain. Hold on a second. You can see them inside the organisms. Whipple disease is very uncommon, as you know, but it is caused by the Bacillus trophorema whipplei, formerly Whippelli, but if anyone is keeping track, the name was recently changed, I think, to better sort of reflect the name of the disease. And we have always heard about Whipple disease occurring in this population of farmers and carpenters, but there's some recent evidence showing that familial cases and suggesting that Whipple disease might be a genetic susceptibility in certain families to an organism that might have a commensal role in other individuals. The classic presentation of diarrhea, weight loss, and fever with some arthritis is one that we know, but if the disease goes unchecked, patients can have severe cardiovascular and neuropsychiatric manifestations, which actually did occur in this particular case. So this is another entity to certainly keep in mind, although it is certainly quite rare when you see those expansile macrophage infiltrates in the upper gastrointestinal tract. Okay, so that takes us through all of our cases of flat small intestinal biopsies. I summarized here all of the entities that one might call to mind when faced with a biopsy from the small intestine that has either effacement of the villus architecture, increased inflammation, or increased intraepithelial lymphocytes. And we did look at many of them during the session, but some of them we didn't get to, but I include them for your reference. So thank you everyone for joining me. I hope everyone enjoys their holiday, and I'm happy to take any questions.
All right, thank you very much for that insightful talk, Dr. Panarelli. As it doesn't look like there are any questions right now from our online audience. I don't know if there are any questions from where you are at Monty.
Questions, anyone? No, you okay? No, we're okay over here too. No questions.
Okay, awesome. Well, thank you again, and thank you everyone for joining today's podcast. And you can find an archived version of Dr. Panarelli's talk right here on our Facebook page, our YouTube channel, as well as our iTunes podcast. And I just want to remind everyone that up next we'll continue our GI pathology series from Johns Hopkins with the return of Dr. Voltaggio and her lecture on colonic polyps, and that will take place Tuesday, November 28th at noon. And if you enjoyed today's podcast, please follow and like our Facebook page and share the lecture with your colleagues. So until next time, goodbye from Atlanta. Thank you.